We are ready to begin our afternoon session of this very exciting conference. So what we're going to talk about in this next brief hour and 15-minute session is kind of an update on the work groups that we have established at different stages through Inc.'s deliberations. Recall that Inc. is focusing on therapeutic areas that are most commonly encountered in neonatal care. And we over, I think by design, I hope it was by design, we developed two kinds of work groups. One work group really focuses on some specific neonatal diseases. And in our first considerations, we had a group formed on bronchopulmonary dysplasia and on seizures. And then we also developed cross-cutting groups that, while having important projects of their own, were also there to support some of the disease processes. And those first two were the ClinPharm group and the data group. Subsequent to that, the last meeting, we added two new work groups, the Retinopathy of Prematurity group and the Haemodynamic Adaptation group. And we're going to hear from all six of those groups now. And then later in this conference today, we hope to add another disease group, the necrotizing enterocolitis group, as well as other cross-cutting groups, the one we heard this morning, perhaps one on long-term outcomes, and also on precision medicine. So we're going to hear briefly from each of the leadership of these established work groups, and I think we'll start off with Heike, if she's here. Okay, on the retinopathy of prematurity group.
No, that's not me. I'm
sorry. On the you're right. Forgive me.
It's me.
It's you.
It's me, okay. Alistair.
It's Alistair Rabba.
Yeah.
No, I'm just kidding. It's Alistair on the retinopathy of prematurity group.
If you don't know who's talking from the back, that's fine. Can I just say that the ROP group, it's very difficult. The ROP group from when we were here last May, we were at the end of it, we were completely bewildered. We really didn't know the game we were supposed to be playing. And it may have been Churchill, I'm not sure whether it was, but it says incompetence is the mother of invention. And we proceeded on that basis. Fortunately, we attended the meeting in March at the FDA, and also very fortunately, because Mark Turner altered all our slides, it came together. And we felt, we knew, at last we felt we understood some of the game. You'll find out that later or not. So I just want to say that the group consists of, the co-chairs are Melissa Liu from Novartis and Boo from a neonatologist from Sweden. And then we have representatives from Melissa Liu and Adina Tukan, both from Novartis and Shire. And then we have two epidemiologists. I won't read the names out because you can read them as well as I can. And obviously we have two neonatologists, and very important, of course, neurodevelopment. Ophthalmology is quite well representative, but in a way we're a spectrum, going from Lois Smith on the left, being rather more basic science oriented, as everybody would know, with her wonderful work, and Anne Helmstrom sitting in the middle, and me on the far right, more a clinical researcher. And then we have representatives from the regulatory bodies. Next slide, please. Now, this is really quite interesting because this has really set some very interesting challenges. First of all, we have to agree what disease we're talking about and its various stages. And this has proved to be more interesting than we thought it would be because, of course, the classification for the disease is really there for the clinician who wants to identify the disease rather than understanding the nature of the response. And it's not as rigorous it's not appropriate for many research processes, many research studies. So we're spending quite a deal of time on working out or trying to devise the ROP classification that is, or shall we say, stages of ROP, and how to fine-tune this classification so that it is appropriate for robust clinical research. But at the same time, we have to ensure that that can be understood by the clinicians who are doing the research in the field, who may not be academicians. So that's where we have to work on endpoints. And in a way, I just want to make one point, that new modalities increase the necessity of more robust measures. For instance, a response to one form of treatment in ROP takes about a week to 2 weeks. No decisions have to be made within that time. If you use anti-VEGF treatment, you may have to respond within 3 to 4 days. It's a different ball game. There are exciting new tools to measure acute phase ROP. There are imaging tools that have been available for some time, but these are now, there's a sort of stage up, a sort of stage, another stage is just being introduced this year. Images is improving, and also how to analyze the retinal vessels. And I mention this because one of the beauties of the retina is that it's the only internal vascular system that you can visualize non-invasively. So that's a fantastic research tool. Also, ocular coherence tomography allows visualization of the various levels of the retina in a way that was not hitherto possible. So we're exploring this. And we've also got to ensure that we have time points for measuring outcome at the appropriate time. I won't go into that. One of the, of course, in the long term, does the baby who becomes the child really benefit from treatments? And one of the challenges is defining long-term outcomes for ROP. These are both objective and subjective, and well, as I say, that is the challenge for the group over the next few months. Next slide, please. So the resources, we're very grateful for the Critical Path Institute for providing these resources. We have of course, we've got the in-house resources I've already mentioned. We've got clinician scientists, both from ophthalmology and from neonatology. We've got epidemiological and statistical expertise, and also expertise in experimental work. So we're very pleased with this, the sort of team that we have. The Critical Path Institute are going to agreed to provide bi-monthly telephone conferences and a couple of face-to-face meetings, which is so essential. And I think the first one, of course, will be in March next year. And we hope to have, well, no, we don't hope to have, we have been instructed to deliver. I've seen Lynn's stern look. She has instructed us to deliver by September 2017. Thank you.
Thank you, Alistair. What we're going to do is go through all of the reports and then have hopefully time for discussion at the end. So just before we move on, I do want to say that we all should take an example from the ROP group, who really jumped on the opportunity to go from being a work shop to a work group. They did a fantastic job of organizing, determining exactly what they wanted to look for, good endpoints. They knew what they wanted from us, and I think they're going to be quite successful, so that was really great. Another group that did a similar job is the Haemodynamic Adaptation, and we're going to hear from Heike on that one.
Yeah, thank you very much. So this group was created out of a workshop last March at the FDA meeting. The moment it's quite small with regard to numbers, so it's me as a neonatologist, Janis Dion is a nephrologist, and then we have Jean Dempsey and Keith Barrington from the existing HIP network. We do think that we will get additional members through our HIP and NeoCirc consortium partners. But if anybody in the room or if you know of anybody who might be interested to join, you're very welcome. We have 2 members from FDA and PDCO. And from the workshop, these were sort of aims and proposed methods we were discussing. And so we are looking at especially at the transition after birth at that time point, but also up to about in the newborn period up to 28 days of age. And one of the points we were discussing that there is actually no international consensus of what is an acceptable blood pressure in the preterm and term newborns, and that relates to low blood pressure as well as high blood pressure thresholds. And if you want to discuss, study any drugs, these thresholds will be very, very important if you develop a study protocol. So we were thinking that we should work on a consensus to form the basis of inclusion criteria for drug study protocols in the neonatal period in the future. And we want to look at thresholds for both low and high blood pressure measures, but including the systolic, mean, and diastolic measures, and also including the type of measurement devices which might be used at the different age groups. So we had discussed the stage approach by looking at the literature review to define appropriate methods of measurements, and then define the normal values for the different age groups, and also exclude influence of medication. And we will also use data from our existing networks and the studies which are ongoing. And then one could consider prospective data collection if gaps in the knowledge are being identified once we are going through the steps 1 to 3. So we think that steps 1 and 2, looking at the devices and the thresholds, will take about a year to complete. And we hope to get a consensus statement published in a journal afterwards so that people can refer to that. Again, we are looking into doing bi-monthly phone conferences, and face-to-face meeting of the working group will be necessary in the next workshop in March. So that's all. Thank you.
Great. Thank you. Next slide.
So,
Oops. Yep. There we go. Okay, so the next groups where we're going to hear from are the groups that were established at our initial meetings. These are our 4 more senior groups, and their projects are either coming to completion, or they are going into the next phase in moving their particular area on. So we hope to hear from each group as to where they are and a little bit on where they're going. So the first one will be our Clem Farm group with Bob Ward.
Next slide, please. I was joined with co-chairs with Carol Allegart and Jeff Barrett, and our first charge, next slide, was to create a white paper. We had a wonderful broad spectrum of input from clinical pharmacologists, from clinical trialists, from regulators, and from parents and nurses, and each of those inputs was really pivotal in deriving the white paper. Next slide. These are the, I think I've covered all, I forgot pharmacometrics and pharmacogenetics, as well as Skip Nelson provided input about ethics as well, all of which influenced the development of the white paper. Next. The white paper was as the best of times and the worst of times. The intent of this was to describe how to study drugs in the newborn As I indicated earlier, we utilized really the skill sets from everybody who participated. We recognize that regulatory documents will only be acceptable to regulators that have written them. But we wanted to provide a comprehensive referenced paper that would provide what we felt were the elements of how to study a drug in newborns. This paper can be used by investigators, by regulatory agencies who may not have a guidance about how to study drugs in newborns. We don't expect it to be adopted in whole, but to provide some information that will be useful. The ultimate document was 76 pages, 131 references, and Pediatric Research agreed to publish an executive summary of this. The entire paper, however, will be available on the Pediatric Research website through funding from Sanofi that will make it open source. This was a new undertaking for pediatric research that created some challenges along the way. But we've overcome those. It's now in press. The executive summary has gone to Nature Publishing Group, and I've been assured will be out in printed form in the next few months. And I understand also that Critical Path will make available on their website the entire document with its full reference set as well. Next. These are the primary authors are listed at the top. I should probably tell you the origins of this paper relate to a guidance published by the U.S. FDA about how to study drugs in pediatric patients, in which there were at least 7 references to neonates and very few details. And so Danny Benjamin and I got together and wrote a reply to the FDA about areas we thought needed to be covered. And so Danny has continued to participate in the writing of this document. Next. After that has been accomplished, we've queried the working group for new directions. A number of those have been suggested but have not been decided upon. One of those had to do with formulations. This clinical pharmacology working group includes a great deal of expertise from industry, from clinical pharmacology, from basic research to clinical applications. In the neonatal period, the drugs that are available are frequently in the wrong concentration. They either are too low and the volume to be administered is higher than neonates can tolerate, or they're in such high concentrations they have to be diluted and contribute to medication errors. And the issues around excipients is a long-standing one in neonatology. Many of the excipients are not adequately metabolized, and so we thought we would try to assemble what was known about formulations. Next. And you'll hear more about interest in the neonatal abstinence syndrome. John Davis has been leading efforts about how we can diminish this. Walter Kraft is here as well. And there are a whole host of issues that we will discuss. I'll discuss some of these this afternoon about how we can hopefully diminish the use of narcotics. Next. And one that has just arisen and will be proposed to the Pharmacology Working Group has to do with adverse events and how those should be rated for neonates. There are a number of unique disorders for the neonate, the interventricular hemorrhage, apnea of prematurity, necrotizing enterocolitis, and so on. And many of these have long-lasting adverse outcomes, and grading the severity of those we thought would be beneficial. from a regulatory standpoint and from a clinical research standpoint. And more importantly, Carol Allegard has a graduate student at the bottom, Thomas, I want to say Salates, who's working on his PhD and is interested in covering this topic. And so he will be helping lead that charge. Next. Thank you very much.
Thank you, Bob. Our next work group will be the seizure work group, whose goal was to help develop a master protocol for the neonatal period, and this one on specifically on seizures. And so Geraldine is going to report for us.
Hi, thanks. And no, I'm not Janet or Ronit, but I think Janet has just arrived, yes? Great, fantastic. So you can help with this if that's okay.
Yeah, I'll do whatever you want me to do. It's fine.
Look, we've been really well led by our two leaders. So I've just put up the list of all the participants in the group, in the seizures group. And just to show you that we had a timeline. And in September, we were to have developed a protocol, a draft protocol. And I'm delighted to say that we do have a draft protocol for neonatal seizures. And that's thanks to everybody in that group who've really worked really hard throughout the last year, meeting regularly with teleconferences and drafting and updating the protocol as we go. So the members of the protocol design subgroup, Janet leads that group. And I just wanted to show you that this is just a few pictures of the actual protocol to show it really does exist. And I think it's available on the SharePoint somewhere, but we do have a protocol. So to me, that's a fantastic achievement. So now what's happening in the group is that everybody is commenting and putting lots of comments in, and there's a lot of work to be done now in updating that protocol and to taking on board everybody's input. But the main thing is there is a protocol. So Janet, I don't know if you want to say something about the protocol design section of the which you lead.
Sure, happy to. I mean, I guess the thing about the protocol design section is we should probably discuss it last, because we really are coming to this section last because it really depends on all the other subgroups. So I don't know if you have the slide with all the different groups and leads. That might help if we go.
Yeah, do you want me
to the one summary slide, because
I think they're just all separate slides, Janet.
Yeah, okay, sorry, there was a slide before that had that. So we have groups that worked on primary and secondary outcomes to define those, a parent ethics section and a drug group, as well as the overall protocol design. And of course, overall protocol design really depends very much on the definition of primary outcome, secondary outcome. All of those other issues inform protocol design. So that's probably the least developed section that we have, and it was really contingent on us deciding primarily the primary outcome, which has been the group led by Geraldine, where we've been struggling with deciding how to define a primary outcome when there isn't, in fact, agreed upon primary outcome. So unlike blood pressure, we actually do know what a seizure is, so that's good. We know when a baby is having a seizure or not having a seizure. But the difficulty in terms of our primary outcome is defining how many seizures how much reduction of seizures is the right amount in order for us to then define how we're going to design our trial around that primary outcome. So I think that's where we are with protocol design.
Okay, thanks, Janet. So I suppose the next part of the protocol has been defining that primary outcome. And as you all know, and as Janet has said, neonatal seizures can be difficult to detect, because unlike older populations, older children or adults, we can see the seizures quite often and we can count them. And in older children, we can say to parents, look, how many seizures did your child have yesterday or last week or last month? But we can't do that for neonatal seizures because we need EEG to detect all seizures. So that has been the first sort of challenge we've had to address, because in order to use a drug, to measure the effectiveness of a drug, we need to detect all seizures with EEG. And as many of you will know, A lot of centres around the world are using, sometimes they're not using any EEG to detect seizures. They're basing their clinical decisions for treatment on clinical detection of seizures, and we know that we miss a lot of seizures just from purely looking at the babies. And sometimes we can treat events that may not be seizures. So there's a lot of both over and under treatment of seizures if you just use clinical criteria alone. Amplitude integrated EEG is a very reduced form of monitoring the brain. It's a couple of channels of EEG that a lot of neonatal units will use. But unfortunately, if we use that tool, we still miss a lot of seizures. So our challenge has been that if we're going to measure the effectiveness of a drug for treating seizures, we need to use multi-channel EEG. So that has to be EEG electrodes around all of the head, encompassing every area, because we know that babies won't have seizures just in where we have a couple of electrodes on the scalp. They will have seizures that can be in the frontal lobe, the central, the temporal lobes, or the occipital lobes. So we need to make sure that we do multi-channel EEG, and ideally with video as well. And that's a big challenge for neonatal intensive care units, because they've been used to using a much more reduced form of EEG monitoring, which is very good. They've had to do that because that's all that was available. But I think for drug trials, we have to use multi-channel EEG. And of course, then how do we? We were struggling with how do we? Number one, we'll have to do a trial in a unit that can do multi-channel EEG. So for our protocol, we have said that only centres will be able to participate if they have the capability of doing multi-channel EEG. So then, what do we define as a seizure? Well, there are criteria that say that a seizure is 10 seconds or more on the EEG. That's an electrographic event. We can identify that on the EEG. But as you all know, in a neonatal unit, there may not be somebody available 24/7 to identify that short seizure at 4 in the morning. So how do we do that? So I think it needs to be centres that have neurophysiology expertise available, or neonatal neurologists that are available to do that. And I suppose we were struggling then with what's going to be our primary outcome, our efficacy measure. What will we measure? How will we know when seizures have been treated adequately? So we decided that the best thing to do was to do a survey of a lot of experts around the world to find out what they currently do and what they measure currently. Because, you know, it's all very well for us as a group to say, look, we're going to measure efficacy based on 80% reduction in pre-treatment levels of seizures, but is that feasible? Is that what people can do? So we did a survey, and we sent out with our colleagues in the Critical Path Institute. They helped us to develop this survey that we sent to as widely as possible, but to those people who we know are currently treating neonatal seizures and are using EEG monitoring predominantly. And so we had 87 responses from neonatologists, pediatric neurologists, and anybody basically who's treating babies in neonatal intensive care units. And when we looked at the experience of our respondents, you know, it ranged, but the median was 15 years. They were a very experienced group, and that was fantastic to get the input of this group of people who are treating babies with seizures for a long time. And basically, we asked them what was important when they were treating babies. Do they look at seizure burden? And by that, I mean, what's the seizure intensity? How many seizures per hour is a baby having? And how long do they go on for? Because when we're counting seizures doesn't really work with babies, because seizures can be 1 minute or they can be 30 minutes long. So you really need to know what the burden is, i.e. how many minutes of seizures are they having. So we asked the respondents sort of, when they're treating babies, are they looking at the burden of seizures? And the answer was that yes, actually, if you look at the breakdown between neonatologists and other groups are the pediatric neurologists and neurologists, and some neurophysiologists. And basically, you know, seizure burden is really important. They are looking at the intensity of seizures. The number of seizures, while still important, it's not as important, and they're not using that as the basis for their treatment decisions. Interestingly, though, when we asked, are you more likely to treat if a seizure was accompanied by a clinical event? And as you can see there, that a lot of people are more likely to, but there's still a lot of respondents who will rely on the EEG only. And of course, if you look at the overall group, it's a bit of a mix, really. Some people are, obviously, if you see a clinical sign, you're more likely to treat. But I think the problem we're faced with is that we must make it very clear for our primary efficacy measure that the seizures must be on the EEG. There must be EEG evidence of seizures. And when we looked at how treatment success is measured for neonatal seizures, what was really interesting is that most people wanted to see complete abolition of EEG seizures. They do, but I think what we have to think about is I think there's two groups, and that's what came out in. We had some open-ended questions in our survey as well, and a lot of people spent a lot of time giving us some very rich information. And a lot of them said, it depends. If a baby's in status epilepticus, I'm happy if I can reduce that burden of seizures by 50 to 80% because that's an improvement. However, if they're not in status epilepticus and they're having maybe 2 or 3 seizures, they want to get rid of them all completely, and they want them to be gone for at least 24 hours. That's very useful information for us for our primary outcome measure, because we weren't really sure. That's what we thought, but we weren't sure that that's what everybody would think. So that's been now tomorrow we're going to have a very fruitful discussion, I hope, about this whole area, because we have to finalise our primary outcomes. But certainly the information we've got from this survey, and there was a lot of other questions as well, of course, and I haven't been able to put them all up there, but we've certainly got a lot of very useful information. And then the next group we have is the secondary outcome groups, and Marilee is here, and she leads that group. And I think there's a lot to be discussed in this group, but particularly, I think when I spoke to Marilee, I think you'll agree that the main thing is what to assess and how to assess it, and when to assess when you're looking at the secondary outcomes. What measures do you use? I don't know if you would like to add anything, Marilee? Just Mike.
Speak. Okay, sorry. Only that we've had some very interesting and lively discussions about what to assess, when we should assess it, and how we should assess it, and tried to reach a middle ground in the protocol that we wrote up. We did break it down in terms of age range. I think that there's a need for safety measures in the immediate neonatal period, primarily focusing on both neuroimaging, looking at CNS structure, and also on function, examining the infant or assessing the infant's abilities. And then short term, somewhere around 2 years, there are some measures that can look at major disability, both cognitive and motor impairments. But there's also, because of the nature of the group that we're studying and the possible effects of the drugs that we're using, there's some concerns that we want to also investigate some of the other aspects of cognition, which really can't be measured. The earliest would be somewhere around 4 to 5. And that's at least what we're currently defining as long-term, although one could certainly argue going longer.
Okay, thank you. And our next group then is the drug-related issues subgroup. And this group are top of the class because they delivered their section of the protocol first, led by Heike. And it's quite a large section, and it's so good that you're now actually just summarising that and reducing it. But certainly we've got all sections that were drafted, and were drafted first, has to be said. And then the final section then is the ethics and parental involvement subgroup led by Rana Pressler. And all the members are here, and there's a lot of work involved in this particular group, and they've reviewed all the literature. A lot of ethical decisions have been, our ethical issues have been discussed, and it's led to lots of discussions, and the draft is just being finalised at the moment for that section of the protocol. So really that's where we're at with the neonatal seizures protocol. There is a protocol, all sections are being drafted, and we have a very interesting subgroup session tomorrow. And we'll have the protocol by October, I think is the final date. Thank you.
Thank you. A lot of great progress on that, on the protocol. So the next section is our bronchopulmonary dysplasia work group, and Robin Steinhorn is going to lead us through that report.
Thank you very much. The next slide shows we also have a large work group, many of whom are, thank you. are with us here today, and I'm, of course, presenting on behalf also of my co-chair, Wolfgang Gopel. Our charge as a committee was to tackle the problem of bronchopulmonary dysplasia. And as our group began to have its discussions, it was clear that one of the big challenges facing all of us in BPD research is the lack of a consistent definition. In part, that has to do with the complexity of phenotypes as we deal with babies with BPD. In other words, a baby who's born at the limits of viability has a very different disease than the baby who is 29 weeks, perhaps after oligohydramnios and high pressures from mechanical ventilation. So we're dealing with that degree of complexity. And we're also dealing with the complexity of the wide variations in practice between units. One of the big problems is highlighted in the fact that when we are enrolling large numbers of babies into trials intended to prevent a BPD, of course, there are many babies who will not develop the disease but still are going to be exposed to a potential therapeutic agent. So how do we deal with that? And some of the agents that we use to prevent or to treat emerging BPD have adverse effects that may not be evident for months or years. Dexamethasone, of course, being the classic example of such a drug. The other concern is that our current endpoints do not necessarily capture those infants who will have long-term respiratory morbidity, and our group feels that that long-term morbidity that creates a burden for many years and perhaps through adolescence and for a lifetime should be an important goal for us. So this just summarizes something that most people in this audience will be very familiar with, and that is the commonly used BPD definitions. Most of us will use some variation of the Shannon definition, which is based on a dichotomous yes-no, whether oxygen is being used at 36 weeks post-menstrual age. And of course, you can already see some of the problems with such a definition. So a child who is on CPAP and room air by the Shannon definition would not have BPD. A child who's on a 4-liter high-flow cannula, an increasingly used but not yet evidence-based support mechanism in the United States, would also not have BPD. There have been attempts to modify the definition. The most commonly used one is the NIH consensus definition, which attempted to grade BPD in terms of mild, moderate, and severe. And perhaps the advance that came right on the heels of the consensus conference is the physiologic or Walsh definition, which uses an oxygen challenge test. So if you compare where we are with BPD with what we heard about with retinopathy of prematurity, there's a great deal of subjectivity right now in our definitions for BPD versus with ROP, where you can all put a picture up and people can all stand around and decide what stage of ROP is this. So defining BPD at 36 weeks, for better or for worse, is the most familiar, widely accepted, and pragmatic measure. It is what is used in many units as a quality metric, so it is something we are all extremely familiar with assessing. The other huge advantage, and one that is should not be trivialized, is the ability to assess it during the initial hospitalization for most babies. And while all of us can remember some babies we have discharged before 36 weeks postmenstrual age, that is a distinct exception. That those advantages are balanced by many disadvantages, including the fact that there is a great deal of residual immaturity of respiratory control. So babies are still on support with oxygen or other vehicles because of ongoing apnea prematurity, problems with their feeding. There is no consensus yet on how we should approach this for the use of clinical trials, where we really need that very definite and objective definition. And Matt Lawn, who's with us today, in 2014 had a really important meta-analysis of clinical trials, interventional trials done over the last 20 years. And what he was able to show in there is only 31 of the trials even had a defined BPD definition, and of those trials, 71% used oxygen use at 36 weeks, and only 6% used the most objective definition that we have available today, which is the oxygen challenge test. So what our group is doing is we are examining the population at the time of enrollment, and we're saving what I think is one of the very exciting parts for the end, and I'll tell you a little bit about where we're going with that. We're looking at 3 endpoints that we are currently evaluating. Can we take the 36-week endpoint and improve upon it because of the many, many advantages? And Matt Lawn is leading that particular charge. Can we refine the definition by removing some of the confounders at 36 weeks and instead tackle this at 40 weeks post-menstrual age? And Judy Ashner and Roberta Ballard are leading that group. And at 1 year, do we have an even better definition? So by that time, children will now have chronic respiratory morbidity, and this could well be a better predictor of longer-term outcomes at 2 to 5 years. So this gives you some sense of the discussions that we have ongoing now. This is a big component of a white paper that we have largely completed. It is not 76 double-spaced pages. Instead, right now it stands at about 36 double-spaced pages. So clearly we have work to do to condense this down and to make this, I think, a very tight, organized set of recommendations. But we're focusing on those 3 endpoints that I just mentioned. So elements such as, should the 36-week endpoint be measured at 36 plus 0 days post-menstrual age? Does it apply to the entire week? How should we approach this? How are we going to handle the children who are on CPAP or high-flow nasal cannula without oxygen? Can we even conceive of having a scale of BPDs? So to take what was done with the NIH consensus definition and move that even a little bit further to a numerical objective scale that then can be modified by use of the right therapeutics. With the 40-week data endpoint, we're working on how we would do the data imputation that would be required for those children that have been discharged. Does this endpoint improve the predictive value for long-term outcomes? One of the challenges with the 36-week definition, of course, is that even children with no BPD at 36 weeks have about a 25 to 30% of long-term chronic respiratory morbidity. So does a definition at 40 weeks improve our ability to decide who is going to have long-term disease? And at 1 year, can we come up with objective measures? Pulmonary functions cannot be done without sedation. Parents will not consent to that at 40 weeks, at 1 year. So do we have other metrics? And Anne Greenoff and John Davis have been very helpful in leading that particular discussion. To add to this, and we've already heard, I think, some very powerful remarks about the parental perspective, we are considering quality of life endpoints. We are learning that parents are not really too concerned about whether their child goes home on oxygen. They are much more concerned with how is my child at 1 year, 2 years at school age. Other endpoints that are very meaningful to parents is, does my child sleep like other children do? Does my child feed normally the way other children do? Does it take me an hour to feed my child, or is it a pleasant experience for both of us? And so we're grateful to Ron for leading that section of our manuscript. So our goal here at our meeting tomorrow evening is to figure out what gaps we still have in the manuscript and to close those and to have the manuscript ready for submission within the next 4 weeks. This is not meant for you to read, but for you to appreciate that the other avenue that our group is pursuing is to develop a core data set having to do with these definitions, these proposed definitions for BPD, so that we can better validate them. This is by no means an inclusive list of every database. Even at the lunch hour, I talked with people who certainly have very important data to contribute. So if this is something that you're interested in, we would be very eager to hear if you're able to help us centralize the data with a core data set so we can better validate these potential outcomes. These particular cohorts have to do with, for instance, the PROP, the Premature Respiratory Outcomes Group, the Canadian Neonatal Network, the German Neonatal Network, Roberta Ballard's NoCLD and TOLSURF research cohorts, the Neonatal Research Network, et cetera. This is about 15,000 babies plus over the last 3 to 4 years. Finally, as we develop our definitions, we think it is very important, and perhaps one of the most important work products for our group is to identify those populations who are at high risk. One thing that's very interesting that we've discussed is the fact that death has always been viewed as a competing outcome for BPD, when in fact, children who die of BPD before they reach 36 weeks are an extreme phenotype. How can we capture those baby children that are going to be eligible for some of the most innovative and perhaps high-risk protocols? And so identifying them will be quite important. Children who are born after intrauterine growth restriction are at especially high risk for developing BPD. Children with severe respiratory distress syndrome, so a child who is still on a ventilator at a week of age, is in a new subset and one that we need to be capturing as, again, a more extreme phenotype, perhaps an ideal child to enroll in a clinical trial. Children with early pulmonary vascular disease are children who also have a high risk for bronchopulmonary dysplasia and chronic morbidity. Can we take the risk calculator that is actually it's easily available. I wouldn't say it's necessarily widely used, but it's easily available on the Neonatal Research Network site, again, developed by Matt Lawn, who is in this room. Can this tool be made applicable to assessing a child's risk for BPD and, again, enriching our populations for enrollment? And last but certainly not least, my co-chair, Wolfgang Gopel, is particularly interested in genetic markers. Is this going to be a way to perhaps enrich populations at risk for the worst phenotype of the disease? So I'll close there.
Thanks, Robin. Just reflects on a huge amount of work and trying to bring consensus where consensus is difficult to get. So we're thankful and look forward to your future paper. The last group is the data group. Tom Diacovo will give us that report.
Thank you so much, and I'm speaking on behalf of my colleagues, Kate Costello and Mike Padula, as well as our data working group, who have been very instrumental in helping us to move forward. So we've been dealing with concepts, terminology, data definitions, and lab values, and how to help the other groups that are specific for disease entities with their particular trials that will take place. So we've been, for instance, working on data elements of what data should be collected in every clinical trial, that there will be a core set of data elements that we would want to collect from every trial that's going to go into place. That can be useful for not only that trial, but for future trials, and then develop sort of modules for each disease entity, being sort of a complementary set of elements that could be incorporated, for instance, into BPD, seizures, et cetera. And we hope to get to that information in regards to working with our colleagues and deciding what should be important for these particular modules to be incorporated into their disease sets. Data definitions, always very clear to work out, as you can see, that we're trying to understand what is the appropriate definition of a disease, how to make that sensitive and specific enough and pragmatic enough for anyone anywhere in the world to be able to understand what we're talking about in regards to a disease and in a clinical trial. We're trying to also have some granularity to definitions in regards to differentiate between very similar concepts, for instance, spontaneous intentional perforation versus neck with perforation. And again, working on this granularity, and Mike Padula is taking the role in that particular area. We do have at our disposal many databases that are available, and people within our data working group that have access to their particular data elements that we'll be using in definitions, and looking for harmonization of these definitions and seeing how much overlap or non-overlap there is in regards to both the database elements and the disease definitions. And we're realizing that this cannot be done alone, and again with the people in this room and other experts. Once we figure out what are good data definitions or data elements, getting their opinions on how they should be modified for use for everyone. And we are, along this line, moving fairly well in regards to the concepts and definitions, and I think most importantly is starting to map these concepts and definitions and seeing how well we can utilize them, for instance, in a CDIS model. Again, if you want to learn more about that, Mike Padula will be talking about that tomorrow. We're also, of course, very interested in lab values, and we know how important they are in defining adverse events and serious adverse events, disease response, diagnosis, and determining appropriate definitions or treatment modalities. The problem that we face is that many of these reference values that have been reported are decades ago and not really relevant to our current patient populations. Again, many are not complete, and many are based on a homogeneous population, which makes it difficult to make them applicable to other populations, as you can imagine. And many are not based on any new disease entities or biomarkers that are currently taking place for our patient population. And most of them, as far as abnormal values, are really determined at the institution of where you're collecting your lab values. There's no consensus. And this just to show that lab values are a moving target depending on your gestational age or postmenstrual age. For instance, your creatinine levels here are different from 25-weekers, as you can imagine, to a 30-weeker, and that they do change with time. So this is a moving target. And being able to have the granularity to go in for each gestational age, weight, disease entity, and pull out that information for ranges of lab values is going to be critical. Now, there has been, and you're not going to be able to read this, but from our colleagues in Pediatric Trials Network, they've actually gone through the past literature trying to come up with information regarding adverse events and serious adverse events based on lab values that were published. Again, it's not specific for the particular gestational ages, but does give us some reference points to start looking at where we may want to have cutoffs for these for adverse events and serious adverse events. But more importantly, we're moving forward with help of the FDA, Jerry Baer, trying to get information on different lab values that exist for previously published trials. And I think the most exciting part of this is working with colleagues at Sick Kids and in Utah, where we're going to actually use clinical pathologists who actually have expertise in defining lab reference intervals. For instance, Khosrow Adeli at Sick Kids has spearheaded a prospective study where he's actually defining reference ranges for all pediatric populations from birth actually up to 18 years of age, and he has real-time data for any particular lab value that you would wish to get information of. And we're hoping to do a retrospective study getting into databases both at SickKids and at Utah, now here at UC Davis, that we may be able to get into and actually start pulling out reference ranges for particular gestational ages, weights, and particular disease entities. And hopefully what our goal is to actually begin to take information from each of the institutions that's involved here that are collecting lab values. We collect so much lab data every day that we can actually put that into a common database. We can prospectively actually generate this kind of information. So our goals are to actually establish the search criteria so we can get the information that's relevant for the particular population, whether you're dealing with BPD, NEC, seizures, understanding what are the reference ranges we should be using for not only gestational age, but for the disease entity. We're also going to start proof of concept, where we're going to take what's already been published, and Dr. Adeli is going to go in and see whether he can reproduce the information that has actually been, for instance, in the creatinine paper that I just showed you. Can he go into a database, take those specific gestational ages and inclusion-exclusion criteria, and generate this reference range for us? And that'll be the proof that we can actually do this in real time for any lab value. And again, we're working on a white paper on the approach and rationale for obtaining such reference ranges. And ultimately, we hope to establish reference ranges not only for Caucasians, but for other ethnic groups, which I think is going to be important for this international committee. And with the goal of having a comprehensive gender, age, disease-specific neonatal database that can be utilized by anyone throughout the world. We do have a white paper, I'm happy to say, that is moving along. We're going to be in our second draft. We'll be discussing it tomorrow about standardization and need for standardization to help accelerate clinical trials. Thank you. Is that okay?
Okay, thank you, everyone. For those of you who have memory issues, as do I, these 6 groups were the seizure group, the BPD group, the data group, ClinPharm group, retinopathy or prematurity group, and the hemodynamic adaptation groups. So they are now all available for discussion, questions, suggestions. Please.
John van den Anker. I have a question for Tom. Wonderful to try to get reference values, but we all know that every laboratory has a different way of doing the assay. How are you going to cope with that? Because that might be challenging not only across, for instance, the UK or the United States, but when you look globally, it might be not that easy.
So that's always going to be a problem, and that was a problem that actually Caliber actually encountered, that they will tell you actually what machine they actually use to get those reference ranges, but they're working on a way to sort of standardize that between instrumentation, that they can come up with a factor that would allow you to get the information that you need. I think because we're looking at ranges, it's going to be much easier than talking about specific value, that they should have some validity with that. It's going to be a problem. But we have to make an attempt to move forward to try to get information, and hopefully if we're able to work prospectively and get information from what people are going to getting at their own institution. So either you're in a trial and you're part of that trial, and we could do it for that specific institution, that may be the way to go. So that's, but again, trying to get that data is going to be important for that. So if you give me your data and we can get reference ranges for your institution, that would probably be the most ideal way to do it than try to do it for everybody on a global scale and just say, here's reference ranges. So that would be the ultimate way to do it, but we need to start somewhere and seeing how well we can put information out, because we really don't have, it's already specific for institutions based on what's in the literature.
So I have a question for both Janet and Robin. So as you're designing your outcome criteria, are you looking at both a short-term outcome and then a long-term outcome for them?
I think in neonatology, it's impossible to avoid an element of a long-term outcome, at least as a safety outcome. Again, the dexamethasone story makes that an imperative. I think our question and the discussion tomorrow night will be how long a long-term outcome could be used as our primary outcome. Is that feasible? Will that be feasible from the pharmaceutical perspective? How will the regulators feel about that? How will parents feel about that? And I think even our lunchtime conversations lead me to predict it will be a lively debate.
For seizures, it is absolutely important that we measure both a short-term and a long-term outcome for the following reasons. People used to have a very nihilistic view about treating seizures because they said, what's the difference? They're very hard to treat. The kid sees anyway. And the real hope that we have is that if we were able to treat seizures effectively, so if we actually found drugs that worked and we actually had achieved our goal of 100% seizure reduction, which would be wonderful, that would then improve the long-term outcome. That is really the whole goal, because we don't think that the seizures in and of themselves, I mean, other than the fact that they're tremendously upsetting to watch, the whole point is are the seizures leading to a worse neurologic outcome in the long term? And that would be both in terms of cognitive and motor outcome, but also later epilepsy. So one thought is, for example, if you have seizures related to hypoxic ischemic brain injury, whether it be focal, like a focal stroke, or diffuse, like global hypoxic ischemic encephalopathy, if you could control the seizures better during the newborn period, you may have a lower rate of later epilepsy. And even if that didn't change the motor disability, so even if there was enough injury to still produce, for example, some degree of cerebral palsy, a reduced rate of epilepsy would be a tremendous success already. So that's clearly important, and we still call seizure reduction our primary outcome because we don't think we're going to get to our secondary outcome unless we do control the seizures better. So it makes sense to still call that the primary outcome, even though our real goal is to improve the long-term neurologic lives of our children. And then the other reason we have to have secondary outcome is for the safety issues, as Robin stated. We don't know whether drugs given in the short term in the newborn period will have harmful developmental effects at a later age. And so both of those issues are key for our so-called secondary outcomes, which in some ways are also primary outcomes.
It's Jacaranda. I agree completely. I think that we have to have an acute outcome, and built in already right at the very beginning a plan for a long-term outcome measure, because we see this with the analgesia work. I mean, you initially have bad things happening, and then later on, when do they resolve, and how do these babies do well later on? And I think that we cannot really, however, wait for 10 years for the outcome to wait for those wonderful drugs that whatever they can do.
It's John Davis, and I'll comment on these comments. We're really hopeful that there'll be a spirited discussion with Neil and Lex and the long-term outcomes group tomorrow, because I think this is really the crux of the matter. And as Robin talks about lively discussion for longer-term follow-up with BPD, as you have compounds like vitamin A and giving babies, injections, IM injections 3 times a week for several weeks, finding that there's a short-term benefit for BPD, but at a year, no obvious benefit. When you talk about Anne Greenoff's high-frequency oscillatory study, there was no benefit short-term, and the only benefits, I think, Neil, at 14 to 15 years, the children who got high frequency had better exercise tolerance. So is that, as we've talked about, a clinically meaningful outcome, and who is going to follow the kids out, besides Anne, that long to try to get to those outcomes? So I think we all recognize that there has to be a short-term outcome, and I like what Janet has said, really, can we get the seizures under control better? And then look longer term. And I think the longer term part is so complicated, as the folks will talk about tomorrow, is because when FDA or the other regulatory agencies or all of us as academic physicians or the companies look at the different long-term outcome assessments, they're all using different tests to decide whether the kids are doing fine or not. And so how do we, with indomethacin, prevent 80% of severe IVH, but we can't, and we know that's a bad thing for babies, but we can't really demonstrate at 8 or 9 years of age anything better than the boys seem to have a little less language skills, or a little better, or the girls have a little bit better language skills if they've gotten indomethacin. So I think those are the complicated issues and why we felt so strongly about having the long-term folks really drill down on this, and couldn't think of two better people than Neil and Lex and the group that they've assembled to help advise all of us on what that really means.
Bob Ward, I'd like to ask Janet and Geraldine about definitions of seizures. In the child who has a surface cortical electric EEG that is normal, yet has tonic-clonic movements that are sustained, are we to not identify that as a seizure? And what causes it?
Yeah, I would say, so I'm a neurologist by training, and I would say that from a neurological standpoint, if we don't see EEG evidence of seizure activity, we just don't call it a seizure. That isn't to say that it's impossible for there to be seizures without electrical activity, because we know certainly in older adults we can, and older children, we can use depth electrodes and this sort of thing to prove that there are very deep foci for focal seizures, for example, that are not captured by surface electrodes. But I think it becomes impossible to say that a child is having seizures without EEG evidence. And I think the newborn brain, although the conductivity is very low, it's sufficiently small that we have a lot fewer worries about these deep foci of electrical activity occurring without there being evidence that there are clinical seizures that are without evidence of electrical activity. Babies certainly make unusual tonic and clonic movements, sometimes even generalized type posturing, and to think that those are seizures when there's no electrical evidence, I think is wrong, in the sense that newborns are almost incapable of having a generalized seizure. They can have multifocal seizures. They can have two independent foci of seizures. But for a baby who's having a generalized physical type event, you would have to expect some sort of electrical signature of a seizure. Does that answer your question?
It does to a degree. It's the deep subcortical source of electrical activity that I think goes undetected at times in the newborn. And that's from a neonatologist, clinical pharmacologist perspective, not from that of a neurologist, I would say.
Yeah, I suspect that doesn't occur that much. I mean, if we think of the babies that we have who have lots of seizures, babies with HIE, for example, who are the prime movers in terms of having lots of different types of seizures, focal and multifocal, I don't think that we're seeing a lot of those types of behaviors. I think the population where it's a little harder to tease out are the extreme preemies who have a lot of unusual tonic posturing. Could we be missing something? I suppose that's possible. I think the physiology is still such that we're unlikely to be missing important seizures by EEG, because in the preemies the brain is even that much smaller, and so the surface electrodes are that much closer to all of the brain compared to, for example, the adult, where quite a few centimeters of tissue and thick scalp and skull and are there between the EEG lead and the potential seizure focus.
My name's Gary Noel. I'm a pediatrician by training, but I've spent the last decade or so really sitting across from regulators getting drugs approved in adults. And I'm hearing this discussion. I'm curious about how the teams have dealt with some of these primary endpoints in trying to focus them on how these patients, these drugs, are changing a patient's feelings, functions, or survival, which to me has been grilled in as really being the essence of getting a drug labeled. So my question to the teams are, have we been focusing at least some of our attention on whether or not these primary endpoints are really going to ultimately lead to our ability to stand in front of regulators and get drugs labeled, arguing that these drugs have affected how these newborns feel, function, or survive.
Keep doing that. I would certainly say that's the important to have a long-term component follow-up built in. In order, and I think the more experience we have with that, for example, with, in any particular area, BPD, seizures, the more confident we might be about our early measures, but I don't know if we can ever get rid of the long-term follow-up component of it. And I agree that it should have quality of life measures as well as specific cognitive and motor assessments.
I think this is Robin over here. I think the problem is that we need these surrogate outcomes to get these studies done in our lifetime. To me, even waiting until a year to 18 months to get our primary outcome has disadvantages. We talk about attrition at 40 weeks and data imputation. What are we going to do at a year to 18 months? How many of children enrolled in clinical trials will we be able to capture and measure again objectively? And that's at a year to year and a half. That again is still a surrogate outcome for the longer term 5, 10, 15, 20-year outcomes. So I think you have to pick somewhere, and I think it has to be feasible for us to move the field forward. So your comments are so important and interesting to me because we layer on that mindset onto a very different population.
Thank you. Ron, you had the last question of the session.
Yes, I just want to comment on a long-term outcome. There are different fields. I think pulmonology, cystic fibrosis, endocrinology, diabetes, oncology, cancer follow-up, in which they can convince their families for really a very long-term follow-up. And I agree with the comment that Robin just made. We need two layers here. One for approval based on enough evidence to go forward. And secondly, an invitation to have really a lifetime follow-up because it may be of some benefit to the child. There's one other comment I wanted to make, and then I'll stop, and that is I noticed on the seizure presentation by Janet, there was no industry representative there. And at least for seizures, this is one area in which we use a number of drugs already, none of which may be approved. And someone is behind either the development of those drugs, and there may be others who are developing new drugs. And it would seem to get that perspective into your discussion would be very important.
Thanks. I think we do have some industry representation in our group. I don't know if it was
not
on
in
the
the
very,
outcome
very
work
long
groups.
slide. Sorry.
Not in the outcome work groups that we could see on the slides.